بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم تسليما كثيرا. At the beginning, I would like to thank the organizing of the second Saudi National Chronic Disease Conference on their invitation to me, as well as even to Troop for their hard work to make this conference successful. Today, inshallah, I'm going to talk about type 2 diabetes in children and adolescent management overview. My name is Abdul Muin Al-Agha, and I am the professor and head of pediatric endocrinology at King Abdulaziz University Hospital. The following points I'm going to discuss in my presentation. First of all, as all of you know, that obesity prevalence has been increasingly steadily, resulting in increased prevalence of type 2 diabetes in children. So for the last 20 years or more, number or prevalence of type 2 diabetes in children were not much. And because of obesity is increasing, the number of type 2 children with diabetes becoming more and more every year. Then I'm going to talk about the management options for type 2 diabetes. We have two options. Number one, lifestyle modification versus pharmacological intervention. And in pharmacological interventions, I'm going to talk about metformin, insulin, GLP-1 receptor agonist. Lastly, what are the indications of bariatric surgery in children, and then summary. As you know, diabetes in children, the commonest type is type 1 diabetes, while we have other forms of diabetes in children, including type 2 diabetes, including moody and secondary diabetes. As obesity prevalence has increased, type 2 diabetes in children and adolescents becomes more and more prevalent year by year. And if we can see the obesity prevalence and burden in Saudi Arabia, we find that in Saudi Arabia, there is about 6.9 million person in Saudi Arabia with obesity. And when they classify obesity into three stages, class 1, BMI between 30 to 35, we have 4.1 million in class 1, while we have 2.1 million in class 2 and 0.9 million in class 3. In children, the definition of overweight, when we have on the BMI chart, the weight is, or BMI on 85th percentile and more. Obesity, when we have a BMI 95th percentile or more. And class 2 obesity, when we have body mass index equal or more than 120% of the 95th percentile for age and sex, or a BMI equal or more than 35 kilogram per meter square, while in class 3, when we have a BMI equal or more than 40 kilogram per meter square. What are the goals of management of type 2 diabetes? Number one, to achieve and maintain near normal glycemic control. Number two, to improve the insulin sensitivity and potentially improve the insulin secretion, which results in improved glycemic control. Number three goal, to identify and treat, if necessary, comorbidities such as hypertension, dyslipidemia, and non-alcoholic liver disease. And the fourth goal, to prevent vascular complication of type 2 diabetes among young age group children and adolescents. When we talk about the options of management of type 2 diabetes, we have two options. Number one, which is a highly recommended option and very necessary, which is non-pharmacological option in children, namely diet and exercise. And this is lifestyle modification. If we fail to achieve the control glycemic control on the non-pharmacological intervention, diet and exercise. Then we go to pharmacological, which is medication. We don't have much or long list of medication in children and adolescents compared to the adult. Adult, they have a long list of medication, while for us, type 2, children, adolescent with diabetes, we have metformin, we have insulin, and we have GLP receptor agonist. And this one, GLP-1 receptor agonist, has been approved to be used for adolescent 12 years and above from Saudi FDA and American or US FDA. If you can see, I put insulin in between metformin and GLP-1 receptor. Maybe in adults, they make insulin the last choice for type 2 diabetes, but for us in children, we make it in the middle between metformin and GLP-1 receptor agonist. We start with non-pharmacological intervention in children with type 2 diabetes, and most importantly, lifestyle modification. And when we say lifestyle modification, we mean either dietary intervention or physical activity intervention. For dietary intervention, we are going to talk how to, what are the methods to control diet and exercise. But very important message to all families that the management is family-centered intervention, is not patient-centered. And children and adolescents who are different from adults. Children and adolescents are still part of the family. So we need the whole family to change their lifestyle, not only the child or an adolescent. We need the whole family to interact with the obesity of their children and adolescent, as well as we need for this child or adolescent with eating problem to have some sort of behavioral counseling. Weight reduction. It's very important and very essential to improve the glycemic control. It's a very crucial component of successful management. So we cannot reach a successful management of type 2 diabetes without a weight reduction. It is a cornerstone in the management. And the lifestyle modification needs to reduce body weight should be initiated in all patients with type 2 disorder. There is no exception that anyone with type 2 diabetes should not to lose the weight. What are the goals of nutritional therapy? What are our goals? Number one, the goal to reduce weight. And when we reduce the weight, we improve the glycemic control by balancing food intake and physical activity. This may include providing small meals to avoid wide glycemic excursion, and to provide a diet that reduces in calorie, but also has essential elements of the growth. We don't forget that. They're still children, they are still growing. So you cannot restrict their calories to the degree that they are not growing, because you know that diet is essential for growth, for height. So we cannot, because we need to reduce the weight to compromise the height gain of the child. So that's why we need to reduce the calorie, but not to that extent that interfere with the growth of the child, different than adults, where the adults already grown up. So whatever restriction of diet is not affecting the height, but here we have to be a balance between reduction of calorie and maintaining the normal requirement for the growth. And the patient family should consult it with a registered dietitian with experience in pediatric nutrition and diabetes as possible. So not only the child and the family, both of them. So what are the recommendation? The recommendation to reduce the consumption of fast food. We reduced the amount of consumption of added table sugar. We reduce high fructose corn syrup, fruit juices, high fat, high sodium, and processed food. We have to reduce it as much as possible. And also, we have to control the portion. We have to educate the children about the portion control education, about meals should be in regular times, avoiding constant snacking between meals. And we have to increase the intake of dietary fibers. We have to increase the intake of fruits and vegetables. In children and adults with type 2 diabetes, the optimal goal is to reduce the weight by 7 to 10%. This is our goal. Although the goal in weight reduction is important, but we have to reduce it gradually. We are not in hurry. We don't like the patient or the child said, Wallah, he lost 10 kilo in 1 month. This is not good. We don't want the weight to be reduced dramatically, rapidly. It's stepwise. The most important thing, reduction of weight in children and adolescents should be stepwise. And after reducing 7 to 10% of total body weight, and then we go to second step, which is the maintaining weight maintenance, that to keep the child within 85th percentile BMI, within 85th percentile, not above 85th percentile of BMI chart. And the average of weight loss is about 0.5 to 1 kilogram per month. See, only 1 kilogram per month in a young boy, in a young adolescent. We are not in hurry. But if someone already pubertal, finish the growth, so the goal is to reduce about 1 kilo per week. So the difference are different from adults. In children, 0.5 to 1 kilogram per month. In adults, finish their puberty, the 1 kilo per week. Physical activity is the most important additional factor, together with dietary control and the lifestyle modification, very important to manage type 2 diabetes with increasing physical activity. Independent of its effect on the body weight, improve insulin sensitivity. So the physical activity has two rules. Number one, to reduce the body weight, and number two, to improve the insulin sensitivity. The study said even with exercise, the person doesn't feel that he's losing weight, but exercise itself, it improves insulin sensitivity. So we have to encourage our children and adolescents with type 2 diabetes to have a regular daily exercise, not only to reduce weight, but also to improve the insulin sensitivity. So we have to advise children with type 2 diabetes, we encourage them to do the following. Number one, engage in moderate to vigorous physical activity for at least 1 hour a day. So daily, it's not 3 times per week, it's not 5 times per week, it is a daily 1 hour. And also, in addition to moderate to vigorous physical activity daily, we have to have, they have at least 3 times per week to have strength training, as well as we have to encourage them to decrease sedentary behaviors, to decrease number of non-academic screen time, because as you know, during COVID, a lot of children and adolescents are forced to learn by virtual, online, but apart from non-academic, apart from academic screen time, we have to limit their non-academic time, television, video game, computer, to less than 2 hours per day. This is the recommendation, maximum 2 hours per day for all, for television, for video games, for computer, for WhatsApp messaging, total of 2 hours per day. Now we come to pharmacological therapy. And pharmacological therapy should go hand by hand with lifestyle modification. So if we fail with lifestyle modification alone, we have to add pharmacological therapy. But pharmacological therapy without lifestyle means nothing. We have many options for children and adolescents. Number one is metformin as standalone. Metformin indicated as a standalone in children type 2 diabetes. Any child and adolescent with type 2 diabetes has hemoglobin A1C less than 8.5% with no other symptoms. 8.5%, less than 8.5%. in metabolically stable adolescent with type 2 and has no contraindication to use the metformin. We have a combination therapy of metformin and basal insulin. Combination therapy with the insulin, metformin with the basal insulin. For whom? For those with hemoglobin A1C equal or more than 8.5%, as well as they have a hyperglycemia symptoms, polyuria, polydipsia, nocturia, weight loss without ketoacidosis. So those with symptoms and hemoglobin A1C 8.5% or more should have combination therapy of metformin and basal insulin. If a child with type 2 diabetes developed ketosis or ketoacidosis, came to emergency room, and I remember last 2 weeks, I had a child with type 2 diabetes diagnosed. He came with severe ketoacidosis. This person during ketoacidosis should not have a metformin. He should be treated like type 1 diabetic, and he should be initiated with insulin and not metformin until the patients become normal, stable, out of the ketosis, out of acidosis. Then we shift back to combination of basal insulin metformin. And then when we control the symptoms of polyuria, polydipsia, and weight loss, and hemoglobin A1C become less than 8.5%, so we could wean basal insulin gradually and keep the child on adolescent on metformin monotherapy alone. Metformin should be added to the regimen only after ketosis and acidosis has resolved and the patient returned back to normal or near normal concentration of glucose level. And lastly, but not the least, which is using of glucagon-like peptide 1 receptor agonist. I'm going to talk later about this group. Metformin is number one monotherapy for children and adolescents with type 2 diabetes. What does metformin do? Number one, metformin decreases hepatic glucose production, decreases intestinal absorption of glucose, improves insulin sensitivity by increasing peripheral glucose uptake and utilization. So metformin is a great medication for type 2, great medication for insulin resistance because it does a lot of effect and a lot of beneficial effects for those with insulin resistance. Unlike sulfonylurea, metformin does not produce hypoglycemia in either patient type 2 diabetes or on obese patients with insulin resistance. So it can be used in obese children and adolescents with insulin resistance, can be used in type 2, and both these category, there's no reported cases of hypoglycemia different than sulfonylurea. With metformin therapy, insulin secretion remains unchanged while fasting insulin level and day-long plasma insulin response may decrease. Metformin, usually we start with a dose of 500 milligram once daily, and then every week in children and adolescents, we increase every week by 500 maximum total daily dose, 2000. Cannot go beyond 2000 milligram per day. Maximum, we increase it over 4 weeks. So first week, 500 milligrams daily. Then we make it 1000. Then gradually till 2000. We can use extended release preparation of metformin that administered once per day for those we are worried of their compliance of using twice per day. Metformin, we have to be careful. We cannot use it in any patient or children or adolescent if they have hepatitis, if they have impaired renal function, if they have cirrhosis. Of course, in the West, alcoholism, alhamdulillah, we don't have it much in Saudi Arabia. And those with cardiopulmonary insufficiency, and those with mitochondrial disease, because it can lead to lactic acidosis. So lactic acidosis is not for anyone using metformin, only for this category of patients. So with normal patients, with normal liver function, normal renal function, normal cardiopulmonary function, there is no risk of lactic acidosis. Lactic acidosis only for this category of patients. Patients taking metformin are advised to take daily multivitamin. Why? Because multivitamin contains B12 and folic acid, which be affected, the absorption of both of them affected by metformin. Now we come to insulin. And here, insulin therapy is not like an adult, they keep it till the end or last choice. But here in children and adolescents, we like it to be started early, especially if the patient with type 2 diabetes, as I mentioned previously, came with ketosis or ketoacidosis. So we cannot manage any child with type 2 diabetes, ketosis loaded with metformin. It is impossible, so we have to start insulin. And those patients with mixed diabetes, I'm not sure in adult population you see a mixed diabetes. We have now many adolescent and many obese children with mixed diabetes. What does it mean, mixed diabetes? Mixed diabetes, he has a features of the child or adult has the features of type 1, namely he has antibody positive, anti-GAD, for example, positive. At the same time, he has a features of type 2 diabetes, namely acanthosis nigricans and obesity. So this patient has like what is called double diabetes. Type 1, antibody positive, type 2, obesity, and acanthosis. In these patients, this category of patients, mixed diabetes or double diabetes, we have to use combination therapy of metformin and insulin, especially basal insulin. And also insulin, as I previously mentioned, if we have a patient with type 2, not mixed diabetes, pure type 2, but the hemoglobin A1C equal more than 8.5% together with the symptoms of polyuria, polydipsia, we have to control him first. We have to control with metformin and insulin. And when the child becomes controlled from the symptoms, hemoglobin A1C become less than 8.5%, then we wean down the insulin and we keep the child on metformin alone. So in children and adolescents, maybe we are different from adult in this aspect of the indication of insulin therapy together with metformin. We have the one of the good medication, one of the promising medication for obesity as well as for diabetes type 2, which is glucagon-like peptide number 1 receptor agonist. Incretins are peptide that produced by intestinal mucosa in response to oral intake of nutrients that enhances glucose-stimulated insulin secretion and lower blood glucose levels. So incretins, which is a glucagon, like peptide 1 receptor agonist, it has effect of stimulation of insulin secretion as well as decreasing blood glucose. That's why we cannot use it in type 1, because type 1, they don't have insulin secretion. Their beta cells cannot produce insulin secretion. So there is no benefit to use GLP-1 receptor agonist in type 1 because they don't have as insulin. So one of the best indication or the action of this category of medication that to stimulate insulin secretion. Administration of GLP-1 receptor agonist stimulate GLP-1 receptor, increasing insulin secretion response to oral glucose. And we have in the market several GLP-1 receptor agonists approved for treatment type 2 diabetes, starting from age 12. Actually, so far we have many medication, especially Victoza and Saxenda, liraglutide, but other form of GLP-1 receptor agonist not yet approved. Liraglutide is approved for children and adolescents starting from age 12 years and above. And Saudi FDA has approved it a year ago, and up to dose of 3 milligrams. So liraglutide 3 milligram is recommended in children 12 years and above, has weight more than 60 kilogram, and their body mass index corresponding to 30 kilogram per meter square or greater, to improve their weight as well as their type 2 diabetes. So it is approved in children similar to an adult. This category of medications incretin mimetics that acts to increase the glucose-dependent insulin secretion, as I mentioned, from beta cells, and helps to ensure an appropriate insulin response following ingestion of meal. They have additional effect of promoting weight loss due to delayed gastric emptying and possibly through acting centrally on appetite center on the hypothalamus. Liraglutide, which is the approved medication in children, administered subcutaneous as once daily. So far, we don't have approval for other forms of GLP-1 receptor agonists like dulaglutide or semaglutide, still not yet approved in children. So the only approved for us is once daily injection of liraglutide. But in adults, of course, they have other forms of GLP-1 receptor agonists approved for them, as well as the oral preparation of semaglutide approved for to use in adults, and it is currently available in Saudi Arabia, but unfortunately so far we don't have it approved in children. Now we come to the last option, which is bariatric surgery in children and adolescents. And we have in bariatric surgery for children and adolescents, we have three types of bariatric surgery options. As you can see in the slide, we have either laparoscopic gastric bypass, we have laparoscopic gastric banding, and we have laparoscopic sleeve gastrectomy. So all these options are available for children and adolescents. And who are the candidates for bariatric surgery? Class 2. What we mean by class 2, that means BMI equal or more than 35 kilogram per meter square, or 120% of the 95th percentile for age and sex, whichever is the lower, with clinically significant comorbidities, i.e. type 2 diabetes, hypertension, non-alcoholic fatty liver disease, Blount disease, SCFE, GERD, and hypertension. Or when we have class 3 obesity, so bariatric surgery for class 2 with comorbidities, or class 3 even without comorbidities. And definition of class 3 obesity, that when we have a child or adolescent BMI equal or more than 40 kilogram per meter square, or 140% of the 95th percentile for age and sex, whichever is the lower. So this is the indication of bariatric surgery in adults. To summarize my presentation, obesity treatment option for children and adolescents are limited. Of course, obesity and type 2 diabetes pharmacological option is still limited, not like an adult. And as I mentioned, dietary intervention, physical activity, avoid sedentary life is the major therapy and major interventional therapy for children and adolescents with obesity and type 2 diabetes. We have to do behavioral counseling. We have to tell the family the success of the management depends on the family as a whole family, not on the child or adolescent alone. Don't leave the child and the adolescent alone managing themselves. Please cooperate with them, help them, walk with them, eat healthy diet with them. And regarding the pharmacological therapy, we have a few options of metformin, insulin, and GLP-1 receptor agonist. And as I mentioned, bariatric surgery may be considered in only exceptional cases. This is not the rule. Bariatric surgery is the last option for children and adolescents with obesity. Lifestyle is very important, and as I mentioned, we have GLP-1 receptor agonist and metformin approved for children. I would like to thank you all for listening to my presentation, and inshallah you enjoy the conference. Thank you very much for your attendance.